Hello and welcome. We will start from where we left in the last part. Let's start. The learning objectives are shown. Please take a look. So, whenever necessary, insulin therapy remains important in diabetes. The insulin preparations include ultra-short, short, intermediate, long-acting analogs, and pre-mixed combinations. It is important to tailor the insulin regimens for optimum glycemic control. That depends largely on insulin reserve in a patient, which refers to the remaining functional capacity of the pancreas to produce and secrete its own insulin. For example, some patients would be managed with a long-acting insulin to maintain the baseline with or without a supplemental ultra-short-acting insulin after each meal. Others may need a variable combination of short-acting and intermediate-acting insulins as pre-mixed preparation because they are able to handle meal-induced glucose spikes. This composite graph compares the typical features of various insulin preparations. Note the onset of action, peak levels, and duration of action of various insulin preparations. This graph compares normal insulin spikes versus a diabetic patient on insulin-matching insulin therapy with meals and basal needs. Insulin administration to a patient can be done through various devices, where none is oral. Generally, insulin is given parenterally, especially in hypodermal tissue utilizing a special syringe that shows dose in units of insulin per milliliter. Broadly speaking, we need a unit of insulin for about each 2 kilograms of body weight. The insulin delivery systems are shown here. Pause the video and explore each one of them. Insulin therapy is effective and safe if used as advised and with all lifestyle modifications. However, there may be adverse effects of which hypoglycemia is the commonest. Hypoglycemia triggers autonomic discharge and can be quickly identified, such as irritability, headache, tremors, tachycardia, sweating, etc. If not corrected, hypoglycemia leads to loss of consciousness and even death. Lipodystrophy at injection sites is uncommon but seen. Injection of animal insulin preparations sometimes led to atrophy of subcutaneous fatty tissue at the site of injection. Since the development of human and analog insulin preparations of neutral pH, this type of immune complication is almost never seen. Injection of these newer preparations directly into the atrophic area often results in restoration of normal contours. Hypertrophy of subcutaneous fatty tissue remains a problem if injected repeatedly at the same site. However, this may be corrected by avoiding the specific injection site. Immunopathology of insulin therapy is rare. At least 5 molecular classes of insulin antibodies may be produced in diabetics during the course of insulin therapy. Immunoglobulin A, D, E, G, and M. There are 2 major types of immune disorders in these patients. Insulin allergy. An immediate type hypersensitivity is a rare condition in which local or systemic urticaria results from histamine release from tissue mast cells sensitized by anti-insulin immunoglobulin E antibodies. In severe cases, anaphylaxis results. Because sensitivity is often to non-insulin protein contaminants, the human and analog insulins have markedly reduced the incidence of insulin allergy, especially local reactions. 2. Immune insulin resistance. A low titer of circulating immunoglobulin G anti-insulin antibodies that neutralize the action of insulin to a negligible extent develops in most insulin-treated patients. Rarely, the titer of insulin antibodies leads to insulin resistance and may be associated with other systemic autoimmune processes such as lupus or erythematosus. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!